Joel Topf for Nephrology Times. I'm here with Dr. Hussain, who's going to be presenting tomorrow at the late-breaking and high-impact clinical trials. He's got something we don't see that often at Kidney Week is a vascular access study, which is, I mean, for the weakness that has in providing dialysis, we should see tremendous research there, and it's great to see some of that here. Why don't you share a little bit about your background?
Sure. So my name is Mohamad A. I'm a vascular surgeon at the Brigham and Women's Hospital.
Yeah.
I'm also assistant professor at Harvard Medical School.
Uh-huh.
And I got involved with this clinical trial as one of the investigators, and really excited to present the results.
So there's vascular surgeons that like doing access, and there's vascular surgeons that avoid it like the plague. I mean, I've seen them all.
Traditionally, vascular access is sort of put at the end of the list. People don't
I
think
would
about
notice.
it as the primary thing.
We've noticed.
Exactly. My personal practice, I'm in a group which is very facile with dialysis access. We have the largest dialysis access group in New England, and we do a lot of complex access.
Gotcha.
With our group-based approach with interventional nephrologists, and vascular surgeons, we do have a large dialysis access practice.
Perfect. And tell me about this trial here.
Yeah, so this is a 30-center prospective randomized controlled trial that compared AV fistulas versus ATEV, which is an acellular tissue engineered vessel, which is grown in the lab.
Okay.
And the objective of the trial was to see if ATEV performed as well as traditional AV fistula with respect to 6 months of functional patency and 12 months of secondary patency.
Now, were you just an investigator, or did you also implant some of these?
I was one of the investigators, and I also got the opportunity to implant some of these in my own patients.
So when you're in the operating room and you're using this acellular, how do you say that?
Tissue engineered vessel.
Acellular tissue engineered vessel, is it materially different than like a graft material, like a?
Yes, completely different than a graft. So the PTFE graft is stiff.
Uh-huh.
This feels more like a vessel.
Yeah.
It's more rubbery.
Uh-huh.
It's 6 millimeters in diameter and about 42 centimeters in length.
Mm-hmm.
And we can configure it in a straight configuration or a loop configuration like other PTFE grafts.
Mm-hmm.
But it handles like a vein.
Interesting. Now, I'm assuming this was a non-inferiority compared to fistula, our gold standard.
This was a superiority trial compared to AV fistulas.
Bold move. A bold move. It's better than fistula, or at least the attempt to make it better than fistula. Okay, and how large was the trial?
So it's 242 patients with end-stage kidney disease who were candidates for either getting a fistula or an AV graft.
And were they all incident or prevalent dialysis patients or instant dialysis patients?
They were on hemodialysis with a tunnel catheter.
With a catheter.
With a catheter.
It's all catheter patients that are going for their permanent AV access.
And they were on with they had a catheter in for a mean of about 4 months before they got their surgical access.
Gotcha. And okay, so vintage is about 4 months. And any important exclusionary criteria?
I think the main exclusionaries, some patients with the optimal anatomy for a radiocephalic AV fistula, more than 3 to 3.5 millimeter vein and artery in the distal forearm, those particular patients were excluded because in those cases, the radiocephalic AV fistula is still quite ideal.
Diabetes is not a problem?
No, in fact,
disease,
we wanted to enroll high-risk patients with diabetes as well as elevated BMI.
And had anybody had a previously failed fistula? Was that an exclusionary?
Some patients had a...
And even the worst of the worst, previously failed fistulas were enrolled in your trial?
Yes.
Okay. And then they were randomized to fistula versus this acellular graft?
Correct.
And what did you find?
Well, what we found was at 6 months, the functional patency was 81% in the ATEV group.
How just because we got an audience of mainly nephrologists, functional patency means?
So functional patency is defined as the fistula or graft is being used for dialysis with 2-needle cannulation for a period of at least 1 month.
Oh, at 6 months you were asking.
We were asking.
That's your primary outcome.
Exactly.
At 6 months, they're using the graft and they've been using it for a month.
And this is adjudicated, correct.
And it's adjudicated. Now what, and it's okay if they've had to go for a second procedure to open it up, or is that okay in that primary outcome?
That is perfectly okay.
Okay.
Part of the second part of the primary outcome, which is a co-primary endpoint, is 12 months of secondary patency. So without abandonment, essentially.
Anything goes. We're still using it at a year.
It's open at a year, exactly.
Open and using it?
So the using it is 6 months for functional patency, and open is for secondary patency at 1 year.
Okay. And what did you guys find?
So the overall, the results were in favor of ATEV. 81% functional patency at 6 months versus 68% for the AV fistula group.
2/3 for the AV fistula, which seems about right in my mind, versus 80%.
Correct.
And you were powered to show that's a significant difference in your study.
Significant difference with
remember, you told me the end. I've already forgot that. What was it?
242 patients.
Is that the biggest access study ever? It sounds huge.
Yeah, in terms of randomized trials, it's certainly
Yeah.
one of the bigger ones.
Yeah.
And this particular technology in regenerative medicine, it is definitely impressive.
Okay, and then the secondary outcome, this 12-month outcome?
The 12 months was secondary patency, which was also a co-primary endpoint,
Yep.
and it was 68% in the ATEV group,
Yep.
and 62% in the AV fistula group.
Is that a significant difference?
So when you look at the outcomes together, which is a global test,
Gotcha.
significant difference.
Gotcha.
Another key secondary endpoint was the duration of access used in the first 1 year, and that was also in favor of ATEV, where the access was used for an average of 7.5 months for ATEV and only 6 months for AV fistula.
Okay.
And what was really interesting was there were 3 high-risk subgroups in which ATEV really drove the outcomes forward.
Really?
And these were women,
Uh-huh.
patients with diabetes, and patients with elevated BMI greater than 30. So we feel these particular subgroups in which it's very hard to mature a fistula, this could be an interesting and exciting opportunity.
Any important adverse events or safety signals?
Yeah, so I think the first important one as a surgeon I want to know was infection.
Yeah.
PTFE infections more than
Yeah.
10%.
Yeah.
So infection, surgical conduit-related infection was 3% in the ATEV group and 1% in the fistula group, so very comparable.
Yep.
And with respect to other outcomes, we saw slightly more thrombotic and stenotic events in the ATEV group, and more need for surgical revision or maturation procedures in the AV fistula group. So overall, they're behaving
Interesting.
similar to what you
What you'd expect.
would
Yeah.
expect, exactly.
Yeah, interesting. Very good. And then, do you foresee any kind of problems long-term down the line? I'm sure there's phase 2 trials where you have longer duration follow-up.
Yeah, so this particular trial, the 2-year follow-up is ongoing at the moment. One of the important things I want to know as a surgeon is, do these rupture?
Yeah.
And so far we've seen 0 cases of rupture of the ATEV and low cases of pseudoaneurysm because of the repeated needle cannulation.
My patients would love to hear loss of pseudoaneurysm. Those unsightly fistulas bother a lot of people.
Yeah,
It really does.
Yeah.
It really does. That sounds awesome. Hey, thank you for joining Nephrology Times. This was super interesting, very exciting, Dr. Hussain. Can't wait to see you present it tomorrow night.
Thanks for having us on.